Hi, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Hudspeth. I'm the radio program manager for MS Focus Radio, and I'm joined by Adrian DeBerry and Dr. Adam Chaifetz, who will be speaking with us about understanding pain in MS. After the presentation, we'll open it up for your questions and comments. I'm delighted to introduce our speakers. Adrian DeBerry is a clinical pharmacist at UF Health Jacksonville and is a clinical assistant professor for the University of Florida College of Pharmacy. She received her doctorate of pharmacy from the University of Florida College of Pharmacy in 2012. Upon graduation, she completed 2 postgraduate residency programs, with a second specializing in ambulatory care. She's board certified in ambulatory care pharmacy and certified in specialty pharmacy. Her areas of practice include neurology, pain management, and specialty pharmacy. She has held leadership roles in multiple professional pharmacy organizations and is passionate about patient education. And Dr. Adam Chaifetz is a board-certified chiropractic neurologist. Since 2008, he has been the program coordinator for the Comprehensive Multiple Sclerosis Center in the Department of Neurology at the Jackson campus of the University of Florida. He manages the program through the interaction of patients, providers, and ancillary staff personnel. He's also a strong advocate for patients and interacts with governmental relation representatives and local federal legislature. Dr. Chaifetz has been in clinical practice since 1987. His expertise has always been in collaborative medical environments. Dr. Chaifetz has run and managed the largest chiropractic practice in Jacksonville, the first chiropractic rehabilitation center director in Jacksonville. He's always been at the epicenter of collaborative care with his patients, utilizing medical physicians in practice. His patients have always benefited from a thorough, comprehensive approach to healthcare. We're pleased to have them both join us to present this important topic today. Thank you for being with us, and I'll turn it over to you.
All righty, thank you. I also want to thank Dr. Adrian DeBerry for joining me here today. This is a special treat where we have an opportunity to interact with 2 different providers in a comprehensive MS center where we both share a passion for patient advocacy. And Dr. DeBerry is probably one of the most experienced pharmacists when it comes to the MS world and the acquisition of MS medications and just dealing with MS related problems and issues. So it's really an honor and a pleasure to have Dr. DeBerry here with us today too. All right, so we can go ahead and get started. If you want to go to the next slide, that'd be great. And you heard a little bit about me. My background is in chiropractic. I'm also board certified as a neurologist in the chiropractic realm. And that's extremely helpful when you are involved in the Department of Neurology here, which is where our MS center resides within the department. Then I've also been a certified MS specialist since 2009. And then just starting in practice only 32 years ago, I've garnered a little bit of information about patients over the years. So I'm hoping to be able to share a little bit of clinical expertise from a different perspective. I'm trained as a chiropractor, but my function here in the center is vast, and it's to help patients get whatever they need in terms of medically or anything else. And so I have always worked very well collaboratively with medical and osteopathic physicians and physical therapists and pharmacists. So this is really a perfect environment that I enjoy practicing in very much. So let's go to the next slide. And this is probably my most impressive credential of all, which is, of course, the old Holiday Inn Express thing. Then if we move to the more substantive slide there, we're going to go ahead and start with the question that so many MS patients pose to their providers, and that is MS painful? And over the years, I've heard different replies that patients have received from a number of different providers that they've had. For instance, I've had patients tell me that maybe their neurologist or family doctor has told them that MS is not painful. MS in itself is not painful. But if you look here, Dr. Maloney, who is a clinical nursing director at the VA, she describes a number of different painful things that we see very commonly with MS patients. And the one thing we're going to talk about is pain in MS, but not everything that's painful in MS is necessarily related to MS. So we're going to go through some things that may be contributing to some of the pain issues that you're having. And then importantly, if you have any questions about medications that we're talking about or medications that are used, please direct your questions to Dr. DeBerry, because she can go ahead and answer the pharmacology or the clinical pharmacology of why certain medicines work for certain conditions. Okay? All right, so let's go to the next slide, please. So the main reason that patients will experience pain in MS is because of the process of demyelination. And demyelination is that process that occurs where the immune system is avidly attacking the nerve cells of the central nervous system. So what does this look like? Well, if you look at the slide on the right, it kind of looks like something extraterrestrial, something cosmic, but really what you're looking at is a representation of white blood cells, T cells and B cells. And what happens in MS is you will see the T cell, for some reason, there's a mechanism in multiple sclerosis where the T cells are activated to go through the blood-brain barrier. And when it does, it activates a series of chemical reactions that in turn create an inflammatory response. Now, if you notice the T cells going through the blood-brain barrier, and it is attacking the portion of the nerve cell that has myelin on it. So the process of demyelination in multiple sclerosis can occur in both the brain area and the spinal cord. And so if you look at the MRI image on the left-hand side, you will see a area in the spinal cord that is a lot lighter than the surrounding spinal cord. This patient has a very significant spinal cord lesion in the cervical spine that spans at least 2 different segments. So if you look at the totality or the size of this lesion, what you have to realize is that the lesion occupies a majority of the space of the spinal cord in this patient. There's no telling what this person's symptoms could actually be, because the clinical findings are much different sometimes than what you see on imaging. All right, let's go to the next slide, please. So this is one of my favorite cartoons, and sometimes people are in pain because of disability, and disability creates lack of physical activity. So let's say, you know, it's January the 2nd and you're on a New Year's kick, and you know, and basically you ready to get in shape. And this kind of exemplifies what most people in their mind do versus what they actually do. And it says they're going to get the diet book they won't read, the exercise bar they won't use, and the CD they won't watch, all for $29.99. So if you're a do it kind of person, then you're actually going to get up and do something as opposed to buy a plan to do it. All right, let's go to the next slide. The first type of pain that occurs in multiple sclerosis may in fact be one of the presenting symptoms that a patient may have when they have an event or a relapse. It's a type of pain called neuropathic pain, and many patients who have MS sometimes will develop a very severe and sharp type of pain in the area of the jaw. And we're not talking about a little bit of a pain. We're talking about a pain that is so sharp and so severe that even the breeze of a fan or an air conditioner on the skin is extremely painful. In cases like this, and it's funny because I just spoke with a patient recently who had been to their dentist, who had been to an oral surgeon, and they were making braces for a patient. And my suspicion was they had trigeminal neuralgia. And in a case like this, probably a splint is not going to work, and having new teeth drilled out is not going to work. So most likely, if the diagnosis is made correctly, there are medications that can be used to control the severity of pain. Now, in terms of this condition, some patients live with this on and off. Some patients live with it chronically. So when we talk about this, we're talking about a very severe type of pain. And sometimes this can occur after a dental procedure. There's no doubt, but the likelihood of that is not significant. Now, Dr. DeBerry, did you want to talk about any of these meds at all that they are mentioning here?
So the medications that are listed in this particular slide focus more on the neuropathic pain. So opposed to some of the other pain type of medications, these are specifically designed to help alter the nerve sensation and transmission of those pain signals. And they all sometimes work a little bit differently. Some require more monitoring than others, and some can affect different organs long term. So that's why it's important to stay compliant with any recommended blood work or monitoring that your doctor has ordered for you.
Right. And another thing too to mention is that some of these medicines have a very wide spectrum of dose that can be used. So if the level of pain is not being controlled, there's usually some liberty to go up on the dosage on some of these meds if they're not immediately effective, correct?
Correct. And
Yeah.
you may see higher doses in things like Lyrica or gabapentin being used in the neurology world specifically for that reason. Everyone's nerves aren't quite the same. So I like to say your nerves kind of do what they want to do, when they want to do it, for however long they want to do it for, kind of like a screaming toddler. And our job is basically to coax that toddler, that nerve, into firing or behaving a little bit better with these medications on board.
That's a great analogy. Thank you.
Mm-hmm.
Okay, so let's go to the next slide and see what we've got there. All right, so this is a puzzling one to some patients too, because what this is a type of neuropathic pain, but this is what I would consider to be an episodic neuropathic pain. So basically what happens with Lermit's sign is that when you flex your chin forward as far down as you can, as fast as you can to your chest, if that produces an electrical shock type feeling going down the spinal cord, this is something that is usually a sign of demyelination. Now, in medicine, it's not an exact delineation of just an MS sign. We see this positive when a person has meningitis. We see this positive when a person has a lumbar disc or a disc problem in their spine. But if you know you have MS and this phenomena occurs when you're flexing your neck forward, then this is something that's not necessarily treated because it's episodic. But some patients are kind of startled by it because they're not really understanding where the origin of the pain is and what's happening. And so a lot of times patients, you know, they don't walk around with their chin to their chest. So if that happens, or they're on a situation where they're maybe on a carnival ride or something, then their neck gets, you know, whipped around, they might feel this weird feeling. So I just wanted to point that out, that is another sign that we see with MS patients. Okay, next slide, please. All right, so the MS hug, this is another one that honestly, we have to educate our neurology residents about this one, because what happens with an MS hug is, imagine somebody about twice your size was coming up behind you, grabbing your ribs and just pressing in, okay? That's the experience that I've heard described by patients that get what's called the MS hug. And what this is this is a type of neuropathic pain, which I think also involves the spasm of the muscles in between the ribs. Mm-hmm. So if you've ever eaten barbecued ribs before and you see the meat in between the ribs, imagine those small little muscles tightening up. And so if you have intermittent nerve signals that are going to those muscles that aren't working properly, it can produce this tightened band sensation that patients will experience. And sometimes, guess what? It wraps around to the front and it can mimic chest pain. So if you are the prototypical patient of high blood pressure presenting with chest pain, they're going to do an entire cardiac workup on you when you might just have a symptom that's related to MS. Okay. And so this would probably be treated with the same medicines that neuropathic pain would be treated with. Now, the interesting thing in neurology is that many or most of these medicines that are used are also used for epilepsy, for seizures, and for headaches. So it minimizes sometimes patients' chances and opportunities to develop other conditions while they're on these medicines at the same time. Another type of pain that we see with patients is a burning type of limb pain. And this, of course, can occur really at any time and in any limb. And it can really occur anywhere in the body. And again, this is due to demyelination. Let's go to the next slide, please. Now, again, Dr. DeBerry can talk about the differences here. Some medications you may have heard their brand name. Other medications you may have heard the compound name. So the whole thing about these, again, is what we're trying to do, folks, is when a pain sensation is present constantly, okay? What we try to do with any intervention that tries to intercede with pain is try to trick the area in the brain into believing that there are not pain sensations present. So think about this. If you go through a doorway and you hit your shoulder on the doorway, what's the first thing you do? You rub it, right?
Mm-hmm.
And you keep rubbing it because the massage, the sensation of massaging helps to take away the pain signals that are going to the brain. So when we see patients that are given certain medications, some of these would be Neurontin, Lyrica, or even Elavil, which is used for, I believe, at least 3 different things, right?
Mm-hmm. So a lot of times you may see that the medications listed here are things that are used in traditional neuropathic pain. So you may find them with diabetics who have peripheral neuropathy or lower limb neuropathic pains as well. And a lot of these medications, like Dr. Chaifetz mentioned, are used in epilepsy treatment, but some of the other categories that you may find them used for is with antidepressants. So things like Elavil or amitriptyline, as he had mentioned, or duloxetine with the brand name Cymbalta. Just because those are antidepressant medications doesn't necessarily mean they don't have other uses. So you may be prescribed an antidepressant to help with some of the nerve-associated pain that you can experience.
Yeah, and please, please, please don't get caught up in the name of a medicine, because I mean, there are so many cross uses in neurology for these medicines, and many of these medicines have been around for decades. So, they're used to using these medicines, and sometimes, for instance, a provider will choose a medicine like Cymbalta, for instance, which has a component of helping depression as well as controlling pain. And one cannot argue that depression generally is part of the picture when you're dealing with pain. So it doesn't hurt sometimes to tackle both aspects of the patient's pain complex. All right, let's go to the next slide, please. All right, and then let's face it, as we get older and as we age, we maybe put on weight, or if we're athletic, we have a bunch of injuries. But if you have a condition that's already present along with your MS, that can also contribute to some problems or management issues. Like, I'll give you an example. I know of an MS patient that's had 3 back surgeries, okay? So he also has spasticity in his legs. So he has to take one muscle relaxer for his back muscles and another muscle relaxer for his spasticity, because the medicines work on different things. And in patients like him, his case can be so complicated, and he's very lucky to have Dr. Silliman as his neurologist, because there aren't a lot of doctors that can differentiate central nervous system problems from peripheral nervous system problems. So he has what we call concomitant conditions, which is 3 failed back surgeries. So if he has leg pain, weakness in his leg, a foot drop, or any issues like that, all of those can be caused from MS, but they also can be caused from back pain. So you have to have a very astute provider to know the difference in how to treat it, okay? But going back to my original statement on pain in general, is that if you have degenerated discs in your back and you're immobile, possibly chair-bound, or using, aids, this can also affect your pain, which may not at all be related to your multiple sclerosis. Okay? And the way they would treat it would be with arthritis medicines or general pain medicines and muscle relaxers. Okay, any comment about that?
No, I think you covered
That's
most
it.
of that, yeah.
Okay. All right, next slide. Okay, so we talked about concomitant conditions. These are conditions that exist at the same time that you have multiple sclerosis. So if a person has arthritis, now this can be any type of arthritis. It can be degenerative arthritis, which comes from aging or weight gain or trauma. If a person has diabetes, neuropathy is one of the most painful conditions that is out there in the field of neurology. So our neurologists that are the neuropathy specialists spend a lot of time with pain management with their patients, okay? And then previous neck or back surgery or multiple surgeries will definitely have not only an effect on your pain, but an effect on your potential mobility also. Now, obesity, I don't need to talk about, has serious effects really on your weight-bearing joints, but it's also a serious problem when it comes to just general health. And then using over-the-counter medications excessively. Believe it or not, if you have pain in your legs and you keep taking too many over-the-counter meds, it may cause another problem that we see, which are headaches that rebound from using too many non-steroidal drugs. And then also just inability to ambulate causes postural tone problems, muscle spasm, and pain when moving. Let's go to the next slide. All right, so if you look at the slide on the left, one would have to agree that both of the people in this picture are going to be suffering pain if they stay in that position for any amount of time. Would you agree? So therefore, you have to look at your posture and you have to say to yourself, if you're in a sitting posture all day long, what's going to happen is you're going to get shortening of some muscles, contracture of some muscles, and lengthening of other muscles. So if anybody's ever broken an arm or a leg or any bone and had their hand or arm in a cast, and you know that sensation when you get the cast off, how awkward it is because the muscles have contracted. So it's really important for a person who has mobility issues to sometimes get out of that posture, to stretch and exercise, whether it's active or passive. And that can also help to minimize pain when it comes to postural related issues of pain. Okay, let's go to the next slide. As a person loses their mobility and they start to use ambulatory aids, you notice a person's center of gravity can shift. So if you look at the animated cartoon on the right, and you look at the gentleman using a cane, his posture is almost perfect, okay? And how do you know that? He's looking forward, his shoulders are square, perfect angle at the elbow. And if you notice, he has a good center of his balance as well as his vision. Now, if you look at the gentleman on the left with the rolling walker, I can tell you right now that he probably has mid-back pain from being perched over like that. Unfortunately, posture in a prolonged circumstance is going to end up causing posture-related pain. So, you know, looking at the way a person ambulates has a lot to do with maybe some of the pain patterns that they experience. And that's why we recommend to our patients to have a thorough evaluation done with a physical therapist and an occupational therapist periodically to see if you have any increased needs for mobility aids that can help your posture and improve the likelihood of your mobility. Okay, let's go to the next slide. One of the biggest issues in multiple sclerosis is a condition that is very frustrating to patients, and that is spasticity. Spasticity is the best way I can describe it to those who don't have MS is imagine your legs being as absolutely tight as they can be and multiply that by about 10. That's what I've heard from patients. It feels like a tightening, squeezing, very debilitating type of feeling that limits your mobility and is painful at the same time. So with spasticity, the options a person has are usually pretty conservative at the beginning. So most of the time, the medicines that are used are going to be muscle relaxants that have a central nervous system emphasis. So I'll let Dr. DeBerry talk about baclofen and tizanidine.
Baclofen and tizanidine, and sometimes very rare cases, benzodiazepines may be used to help with severe spasticity. With those medications, you see them used a lot in other types of muscle spasms that aren't related to multiple sclerosis. But the big thing with these medications is they're very sedating. So when you're starting one of these medicines, you want to make sure that you have enough time to figure out how your body adjusts to receiving these medications. I usually counsel patients to, if they're going to start a new medicine, start it perhaps on a weekend so it's not interfering with their focus and they can understand how their body responds to it, versus, starting at the beginning of the week, you're trying to function and still work and you may have increased drowsiness. So these medications, usually that's the biggest side effect or complaint I hear from patients. In addition, with tizanidine, you want to be mindful to continue to monitor your blood work for your liver function, as that can be impacted by tizanidine as well.
Yeah, so, and it's also important too, when we talk about concomitant conditions, patients have to be careful in mixing the muscle relaxers, correct?
Correct.
So if your family doctor is giving you something for your back, you need to let your neurologist know who might be giving you something for your spasticity. And generally speaking, I think most of our providers are going to go the route of starting on a conservative path, which is going to include oral medications and then physical therapy, probably a balanced gait analysis, just to see, what the risks are for the person. Okay, let's go to the next slide. Now, some patients, unfortunately, because of the aggressiveness of their condition or the severity of their condition, they end up having spasticity that is so severe that it limits their ability to walk. They literally feel like they have 1,000-pound weights on their thighs. And so when we see a patient that is maxed out, totally maxed out on the oral amount of baclofen, for instance, and that's usually the go-to that I've seen has been baclofen. I'll never forget one of my really good friends who has MS now. He has a baclofen pump, and he's not a super big guy. He doesn't have, a large torso, so he doesn't have a lot of meat on him. And when I showed him the baclofen pump, I said, you should really think about this because your mobility is so hampered. And it took me a good couple years to get him convinced to even consider it. And once he did, he was very, very happy he did. So those of you who are in a position to where the spasticity is that bad and you know, you're at the top of what you can take and your doctor can't give you anymore, the baclofen pump is a decent alternative. It's not that big of a device. And what you're looking at the slide on the right is the procedure of refilling the pump. Okay, now the downside is it doesn't just magically appear in your abdomen. It has to be implanted, and generally a neurosurgeon or a pain management doctor are the ones who are going to do that. And then several of our neurologists monitor these. And so you do have to have a good team in place of either pain management, neurology, anesthesia, that not only can put these pumps in, but can also manage them for you too, because there is nothing worse than seeing a patient withdraw when their pump is dry. So once a person commits to this, they have to have a practice that can manage the ongoing, you know, management of it. All right, next slide, please. Okay, so we're in the COVID era and we've heard about viruses. Herpes zoster virus, you may not be familiar with the term herpes zoster, but maybe you are with the term shingles. And shingles is also a viral disease, but the way it presents is usually with a skin rash. And it's a very peculiar condition because many times it follows the course exactly of the nerve that we see, for instance, in the mid-back or underneath the armpit area. And this is a very painful condition. And now there is a vaccine for it. Can you tell us a little bit about the vaccine and what's recommended for MS patients?
So there's several shingles vaccines that are currently available. The newest vaccine is actually called SHINGLES. It's a little bit different compared to the others. The others shingles vaccines actually contain the live virus, whereas SHINGLES does not contain a live virus. It actually contains a recombinant adjuvant version, which is a mouthful to say, of a vaccine. So it basically protects you against the herpes zoster development later on in life. Now with SHINGLES, it's debated whether or not officially it should be given to immunocompromised patients. There's been a lot of discussion in the medical world about whether or not it's okay or not okay for immunocompromised patients. And typically, because patients with MS may be on disease-modifying agents that are going to be altering their baseline structure of their immune system, any vaccine that's given, they're not going to mount an immune response like someone who's not on an immunosuppressant would. So for instance, if I'm not on an immunosuppressant and I get a vaccine that's an inactivated vaccine, I may have 90% protection against whatever the inoculant is, versus someone who may be on an immunosuppressant may have 50, they may have 45, they may have 75. There's not really a standard when it comes to the immunosuppressed patient. So I usually encourage people to have that discussion with their doctor if they're considering a shingles vaccine, specifically with their neurologist if you have MS, to weigh the risk and benefits for your individual case. But if you're on a disease modifying agent, you should avoid the live shingles vaccine. Do not take that at all.
Thank you. Great. Thanks so much.
Oh, one other thing to add too about post-herpetic pain and shingles. This is an area where you can see not only oral medications used to treat those pains, but there are some topical agents that can help with that too.
Like what?
Like a lidoderm patch or lidocaine
okay.
patches, for instance.
Okay.
They can be placed topically on the skin to relieve it at the site. Oral medications are still recommended to be used kind of in conjunction with that, but the topical agents do provide relief for patients that's very immediate and right to the site.
And for some of you who have been put on some of the oral medications in the past, you may remember that your doctors were sending you for a number of blood tests, one of which was the VZV, just to make sure that you have an immunity to varicella before being put on that medicine.
Mm-hmm.
So we do see this sometimes, and the telltale sign is usually the rash that corresponds with the pain. It usually is a pretty painful condition. All right, let's go to the next slide. And they used to use steroids to treat it, I believe, didn't they? Before they had any other antivirals.
That may be the case. It might have been before my time.
Yeah, I think it was.
Yeah.
It actually was. Okay. So anyway, Dr. DeBerry covered pretty much what we needed to about that. Let's go to the next one, please. Okay, now this is a real important thing for some patients who may be newly diagnosed, maybe haven't had MS for a long time, or maybe they, just were never told this. But if you call your neurology office and you tell them that you're having increased pain and you think you're having a relapse, I don't think they're going to think you're having a relapse. And the reason is because pain is not one of the things that we generally associate with a neurologic demyelinating event. So what is a relapse? A relapse is usually a pretty significant change in symptoms, which can produce things like weakness, visual problems, numbness, maybe some difficulty with cognition, dizziness, balance, maybe a trigeminal neuralgia or a Bell's palsy. These are some of the things that we look at. Now, what constitutes a relapse? Something that's going to be there for 24 hours or longer. So I think in my last lecture, I talked about a phenomena where if a person gets overheated, that they will mimic symptoms of a relapse. But the way you know it's not a relapse is that the symptoms abate in a short period of time. So pain is not something that we generally associate as a neurologic event. We look for something more clear-cut that's measurable. So weakness, sensation alteration, cognition alteration, dizziness, balance, gait problems. Okay, when we see weakness or numbness, a lot of times it's just one-sided. All right, let's go to the next slide. And that's why if a person is on a disease-modifying therapy for MS, it is not going to treat the source of their pain, okay? And so this becomes the quest of the provider and the team to figure out where the source of the pain is coming from, all right? So yes, I will agree. If you're a brand new diagnosed patient and you've never started on any therapy, you're gonna have a bunch of inflammation in your nervous system that's gonna create symptoms for you, no doubt. And within a period of time, your medication regimen is going to stabilize that. But please understand that the medicines you're taking for your MS are not designed to treat pain. And so I don't want you to get discouraged, because pain has to be looked at according to some of the avenues that we looked at already. Okay, let's go to the next slide. And ways to tackle pain in MS. Okay, next slide. So we talk about physical therapy. Now, physical therapy, like pharmacy, like medicine, you're best off when you find people who are qualified in the field of MS. So there's Dr. Heather Barksdale, our wonderfully talented doctor of physical therapy, MS certified, neuro certified. She is top of the line when it comes to qualifications in dealing with MS. So we have a very intricate way to do balance testing on a patient, design a rehab program for them, and institute home therapy, which is going to enable them to continue some of the things that they've learned in physical therapy. And if you just look at these pictures, you'll see every one of them are smiling in these pictures. So you know it's good stuff, okay? Let's go to the next slide, please. And then massage and chiropractic care. As we get into what I call the complementary realm, not alternative, but complementary. Okay, these therapies are used in conjunction with traditional therapies such as medicine, physical therapy, acupuncture. It's great to have a whole armamentarium of things to use, because as we've talked about, if you have pain that's due to posture, medicine is not going to stretch tight muscles, and medicine is not going to exercise muscles that need to be worked. So sometimes if you do go the extra mile and you exercise as best you can, you may require massage and possibly some chiropractic therapy to help you in doing some of the sports or workouts that you continue to do. I have patients that I have seen. I saw my first MS patient in 1990, and I still have MS patients that I continue to see on a regular basis, because for them, it works for them. And just to let you know, in England, they did a study of the MS Society in England, and with it being a socialized medicine country, they found that about 32% of patients with MS utilized chiropractic services. So that's completely out of pocket. Okay, so as you know, most people don't pay for things that don't work for them. And I encourage you to look at massage therapy, myofascial therapy, and chiropractic therapy, because if you have benefits for them, they can work with your team to help minimize your pain. All right, next slide. And then pain management. When I see doctors of all types, it doesn't matter what their distinction is. When I see a doctor refer a patient immediately to pain management, a lot of times I'm discouraged by that, because what they're telling the patient is that their pain is not going to go away. And pain management is not usually a short-term management solution. It's usually a long-term solution. So pain management can be extremely difficult in patients that have a number of conditions going on, okay? So my recommendation is always to start with the most conservative approach, and naturally consider pain management if you have chronic pain. But if you have acute pain that is not long lasting, pain management is probably not the first choice as far as I'm concerned. I think there are some other more conservative options before going that route. All right, next slide, please. All right, so here at UF, before the whole COVID epidemic started, we were offering yoga and Tai Chi classes to our neurology patients here because we see Parkinson's patients, all types of neurology patients participate in this, and it helps not only with balance, but it helps with peace of mind too. Next slide. And then here you'll actually see, this is an MS patient doing an adaptive sports through Brooks Rehab here, actually getting out and doing some surfing. All right, so my advice is to find something you enjoy and get out there and do it. Next slide. And then also, if a person has pain for any amount of time, pain is something that grades on a person. And neglecting the effects of pain on yourself and your family can be devastating. So please consider the mental aspect as much as the physical aspect of your condition, because without decent control of depression, it's almost impossible to get a handle on pain management. Okay, next slide. And then conclusions. The takeaways from this that I would like you to know is that just because you have MS, it's not a given you're gonna have pain, okay? Because, I mean, I know people who you wouldn't even know have MS. You look at them, they maybe don't have a lot of complaints. They maybe don't have a lot of concomitant conditions. Understanding whether the pain is acute or chronic. Okay, if you sprain your ankle today, you're gonna fix it today. If it hurts in a week, you're gonna be concerned. If it hurts in a year, that's when you need pain management, okay? So how the pain is affecting you, how it occurred, what it's due to has a lot to do with how we're gonna correct it. But I'll bet you many people neglect the fact that they're just inactive and they're deconditioned, and that sometimes it's gonna have to take a little bit of pain to stabilize your pain to get back in shape, all right? Neurogenic pain can be treated medically. Dr. DeBerry, we talked about several medicines that are used that if you're not on it, you can talk to your neurologist or your pharmacist about it. Understanding that increased pain doesn't always mean you're in a relapse, okay? But that doesn't mean don't call your provider and report your pain if it's new and different. It doesn't mean don't report your pain to somebody, but what it means is that most likely a relapse is probably not in the picture. Symptom management can include a multitude of things, which includes medicines, activity-based things, and counseling. So now that we're in the COVID area and we have to use media interaction, utilize these resources that you have to exercise, to get together, and to network with people who are in the same circumstance. It's giving us the opportunity to give you the same presentation that we've done in person and be able to enjoy, hopefully, some information that you'll learn today. Next slide, please. And whatever you do, you've got to stay positive, you've got to stay active, and you've got to stay connected. And you have to make sure that you are always informed, because I can tell you in medicine, there are varying opinions about varying things, and just being educated about your options is always the best way to go. So I appreciate your time, Dr. DeBerry. I appreciate you being here. And last slide will tell it all. If you have any questions, be more than happy to address those. Thank you all so much for your time today.
All right. Thank you, Dr. Chaifetz and Dr. DeBerry. We are going to start taking some questions. We do have a couple in chat, and let me pull up the how, if you have a question, you can send it to us via chat, or you can also use the raise your hand feature if you would like to ask your question. To raise your hand, just click the screen to pull up the menu, select more. It's the icon with the 3 dots, and click raise your hand. I'll unmute you, then a button will appear on your screen to ask you to allow me to do that, and then select allow. So we do have a couple of questions. Group chat is also the other way to ask a question. The first question is from Rachel. I'm on a different medication for neuropathic pain, but still have major cases of MS hugs. What can be done other than medications to help relieve the pain until it subsides?
You want to take that?
Go ahead.
I would say what Dr. Chaifetz was emphasizing is being more physically active to try to reduce the likelihood of that happening. And then also, see what your triggers are. Is it something that's temperature regulated for you? You may want to look at options as far as maintaining your cool temperatures as an option. But for immediate relief of it, usually it's like a muscle relaxer medication. But sometimes that works and sometimes that doesn't. That's the hard part about it.
I'll tell you what I would think about, though. You may be able to try a TENS unit. A TENS unit is relatively inexpensive. You can get your doctor to prescribe it and go to a medical supply place. But a TENS unit is, pretty safe thing to utilize. And of course, it's not going to have any effect on interaction with your medications. Are you familiar with what a TENS unit is?
So this question came in chat, so I'm not sure if they would.
Okay, so they can talk to a physical therapist or an occupational therapist about a TENS unit. And a TENS unit is just a very small electrical device with some electrodes on it. And it can be powered by the person. They turn it on and off, and they're able to control the frequency of it. And sometimes the stimulation of TENS can help with neuropathic pain, especially if you're already on medicines. Your doctor may not feel comfortable with stacking more medicine on you. And so I see that as a potential safe alternative for something that may be a neuropathic pain related issue.
And there's a follow-up with where would it be placed?
Probably right in the area of where you're feeling the start of the hug at the spine, both sides of the spine, where the muscles are, because what you're going to do is you're literally going to stimulate not over the bone, but to the side of it where the nerves are. All right. And what a TENS unit does, just so you know, a TENS unit is an electrical device that sends signals up to the thalamus in the brain and tricks the area that perceives pain into thinking there's not a pain response present. So it's kind of like when you hit your shoulder on the doorway, you're rubbing it. It's that same phenomena of trying to trick the brain into thinking there aren't pain signals present.
Okay. And you wouldn't place a TENS unit on actual bone, is that correct?
No, no, you don't. No, because it's a nerve stimulator.
Okay.
That's what it stands for, transcutaneous electric nerve stimulator.
Okay.
So what you're doing is you're stimulating cutaneous nerves, and that stimulation is supposed to trick the brain into thinking that there isn't pain present. But the brain's pretty smart, so it doesn't always work 100%.
Okay. Again, if people have questions, please use the raise your hand feature in the app or send your question via chat. To raise your hand, click the screen, pull up the menu, select more, the icon with the 3 dots, and click raise your hand. I'll unmute you. Then a button will appear on your screen asking if you want to allow me to do that, and then just select allow. We do have a couple other questions and just a couple more minutes as well.
Okay.
Tricia asks, I have MS hugs and find it more difficult to breathe lately. Can the hugs cause a decrease in lung function?
So that's a great question. We're not aware that it does, but if you actually feel difficulty breathing, you certainly need to have some pulmonary function tests done, and you need to have that investigated because you may feel like you can't breathe. We need to make sure of that. And that's something that your neurologist, it's not a hard thing to do. There, you just have pulmonary function tests done. If you come out with clean pulmonary function tests, then at least you know that.
May I have your attention, please? May I have your attention, please? We'll be conducting tests on the fire alarm system.
Fire alarm.
Please disregard all alarms. May I have your attention, please? May I have your attention, please? We'll be conducting tests on the fire alarm system.
We heard
Disregard
that.
all alarms. Thank you.
Sorry, folks. But yeah, that's it.
And keep in mind, there are some medications that can actually affect your breathing and your pulmonary function. So make sure you have your medication list reviewed to check and make sure that there's no medications that can be contributing to reducing lung function.
And then in another rare case, if you're on the medication Copaxone, or you're on a glatiramer acetate, which is the same as Copaxone, sometimes an injection can cause symptoms that mimic chest pain. So please also keep that in mind if that's your specific condition. Are you finding it after injecting, or is it happening intermittently? And then is your breathing actually affected? Let's check that out for sure.
Okay, and the final question is from Deborah. Is the MS hug typically a constant pain, or does it come and go?
My experience is it usually comes and goes. That's not to say some patients, unfortunately, don't experience it a lot, but I've never heard of it being 24/7 constant.
Okay, well, that is all the time we have for now. If you missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus Radio SoundCloud page and our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for time and access information. Our next teleconference will be Tuesday, August 11th at 3 p.m. Eastern with physical therapist Patricia Bobrick, and the topic will be managing MS symptoms with rehab. Our sincere thanks to Dr. DeBerry and Dr. Chaifetz and all our attendees for participating today. Thank you so much. Any final thoughts for today?
Just would love to thank everyone for participating in this, and stay, in communication with your healthcare team, and stay safe in this environment. But even though we're all contained, don't let that be an excuse to not be active and take care of yourself. Okay, this is an opportunity for folks to focus on themselves. And Dr. DeBerry and I appreciate this opportunity so much. We really do.
All right. Well, thank you guys so much, and stay safe in Jacksonville, and we'll see you again soon.
Thank
Thank
you.
you.
Thank you.